So NAPCRAG is thrilled to sponsor this event because we're committed to building collaborations across the world among primary care researchers to enhance and improve primary care in the United States, all over the world, and we have a lot to learn from New Zealand and others in this series.
Primary care remains the largest platform for healthcare delivery in the United States, and as Dr. Tilyard will teach us tonight, we have a lot to learn from other countries who are steps ahead of us in trying to achieve what we call our nation's triple aim: improvement in population health, more satisfied patients at a lower cost than we currently deliver health care.
We struggle in the United States with the way in which we use health information technology. We've got real interoperability problems, a real lack of consensus about a number of different standards that allow us to share information. So New Zealand and the way in which they share information across the district health boards, very productive. We've got some things that we can learn about the way in which they collaborate, but they operate a far more centralized system than we do. And so there are real obstacles that we're going to struggle with in terms of the private sector, public sector, the way in which states use information. Having said that, we've got some terrific examples in this country for the use of big data. And the founder of the PCPCC, Paul Grundy from IBM, big data is something IBM knows a little bit about. It's something that is revolutionizing how we're doing research, not just in clinical care settings, but in public health.
Professor Murray Tilyard, his career is characterised by the drive to translate evidence from research into best practice in the clinic. And we are delighted, again, to be able to provide a broader US audience for his innovative work, which has been very influential in the New Zealand primary healthcare system.
Best Practice Advocacy was formed in the 1990s, where we actually wanted to make sure that there was unbiased information provided to general practitioners, family physicians, so that they could make the right choice. And we've demonstrated that with good focused education you can change people's habits of a lifetime. And the return, both the clinical return and the financial return, is quite outstanding.
Hello, my name's Caroline Beresford. This podium was not adjusted for me. I am Chargé d'Affaires here at the New Zealand Embassy. I'm sure that our ambassador would have loved to introduce our speaker tonight, but he's asked me to do it instead, as he's tied up elsewhere. So tonight we're not hosting the event, we're just providing the venue. So I wanted to say thank you to the American Board of Family Medicine for doing this. I understand this is one of a series of embassy conversations that was kicked off last year, and we're really pleased to be part of that program this year. Some of you might know that the United States and New Zealand have a science and technology cooperation agreement, and one of the elements of that agreement is the innovation in primary health care. I think that's it. I'm sure Michaela will correct me if I'm slightly off there. And tonight we have a visiting fellow who's here on sabbatical at the Robert Graham Centre, Professor Murray Tilyard, who hails from my hometown and my alma mater, in fact, Otago University, a lovely university based on the original Edinburgh University. Dunedin's a very Scottish town, and you'll see he's provided his first slide with a picture of the railway station, which I think is also Scottish architecture, and one of the iconic buildings in New Zealand. It's a very cold place. You have to be very hardy to come from New Zealand, from Dunedin. So without further ado, let me welcome Professor Tilyard.
But before Professor Tilyard joins us tonight, I just wanted to say a thanks to Ms. Beresford and to the New Zealand Embassy for hosting us tonight. I'm Andrew Bazemore. I am a family physician and the director of the Robert Graham Center for Policy Studies and Primary Care. And we are really thrilled to be jointly hosting this event, not only with the New Zealand Embassy, but with the help of the North American Primary Care Research Group and the American Board of Family Medicine Foundation, who collectively have felt for a number of years that the United States could go a long way in opening its ears and eyes to the potential lessons that are available to us from around the world and how to better implement a primary care platform in the United States. And I can say personally, having visited New Zealand, that I have been very impressed over many, many years with the ability of a small country to adapt some of the best lessons themselves from other parts of the world and improve on them and engage in continuous learning. Their periodicity of reform is so much more rapid in the United States that it'll almost pass you in the blink of an eye compared to our 40-year cycle between major landmark health reform. But there couldn't be a better time, I think, than right now to hear from Dr. Tilyard and speaking about ways in which we might better engage in population health, one of the key elements of our triple aim for healthcare in the United States, than now. And I'm really excited as well to welcome Dr. Tilyard. Thanks to our co-sponsors, and with no further ado, thank you for coming up.
Thank you. It's a pleasure to be here in this beautiful city. For a number of reasons. One is my oldest son, Alan, actually is in the embassy here. I have 4 sons, number 1, number 2, and number 3, and number 4. So he's number 1 son. But it's great to be here and for the opportunity of spending time with the Robert Graham Centre. So I'm a general practitioner. I'm proud of being a general practitioner, and so I'm most probably very biased towards primary care. I enjoyed putting this presentation together. I started with 250 slides, and I didn't know how many to remove because I thought they're all so good. So hopefully you do enjoy and gain some experiences from what I'm going to talk about. I suppose I'm a funny academic in that I graduated in 1980, dual qualifications in internal medicine and family practice, but I've always liked a bit of business as well. So I've set up a number of organisations listed as such. In New Zealand, they all have charitable status. That means we're not-for-profit. We pay no income tax. Any profits must go back into health care in the community, which is what I like. So the key is we're after quality improvement, cost reduction, containment, best practice advocacy. How do we actually get change management there? Education, working as teams, standards and promoting primary care. So, a wee bit about New Zealand, or Aotearoa. First of all, it's not part of Australia. It's well, I said I wouldn't swear, but I was going to say it's a bloody long way from Australia. It's about 3.5 hours flight. But we love Australians sometimes. We've got about 4.5 million people in New Zealand at the moment, predominantly of European descent. So I can trace my ancestry back to when we were given assisted passage by Her Majesty the King or Queen, because we were convicts into Australia, which I think is why I have no earlobes. There is an association with felons and a lack of earlobes. We have a significant Maori population, our indigenous people, who are protected under the Treaty of Waitangi, as well as the Pacific and Asian people. The Maori population is a very young population. Only 5% are older than 65. Our health system is predominantly a publicly funded universal coverage. Government funds 82% of healthcare. The rest occurs through private contribution. The level of insurance cover is actually very low. It's only about 4 to 5%. Most people would have private insurance for what we would regard as elective surgery, knee and hip replacements. Any acute care is undertaken within the public systems. We spend about 10% of our gross domestic product on healthcare. And our life expectancy currently is 79 for males, 83 for females, but there are ethnic discrepancies. There are differences, particularly between Maori and non-Maori, which we're trying to address. As a country, the Ministry have adopted the triple aim of quality improvement, so best value for public health expenditure, improved health and equity for the entire population, and of course quality, safety and a positive experience. Having recently been in the hospital, I wouldn't regard it as a positive experience. I regard it as the forest. If you're in the forest, get whatever you need and get out as quick as you can, because forests are dangerous. I've decided the hospitals are dangerous and best if possible to be avoided. This was New Zealand's health system in the past. It was chaotic. It was a jigsaw puzzle with no one actually knowing how to put the pieces together. So remember 1980, life was much simpler in 1980. My male patients all died rather quickly at age 70, usually on the golf course of a quick coronary. It was quick and it was cheap. Now my male patients are living into the late 70s and 80s. They have, as what one of them said, I have Crumble's disease, doctor. Everything is crumbling round me. And that's part of the issue that we have to deal with. So ageing and multimorbidity. Our populations are getting older. Long-term conditions are on the increase. The complexity and intensiveness of healthcare has changed, certainly in my practicing life, and it's more specialised and, I would suggest, even more fragmented. One of the issues, or one of the advantages, is that we have access to large national databases. Do remember there's only 4.5 million of us, which I understand is most probably a very small city, which are spread over a rather large distance. But it's quite good. I think I've visited all 1,200 practices, and most probably have met at some stage all 4,500 practitioners. But we can combine the pharmaceutical database, which is all prescriptions, the primary care data set, the New Zealand National Minimum Hospital Discharge data set, and census data can all be linked through a unique identifier. In this case, for these purposes, it's through an encrypted identifier. We looked at chronic conditions from a primary care perspective, and we found that there's just over 1.5 million. So of the 1.5 million of us have at least one or more chronic conditions. The range is between 1 and 15. Above 15, you've hit the jackpot and no one actually counts above that number. 20% had 2 conditions, and the most chronic one was pain. Pain as determined by regular analgesic and or opiate prescriptions, particularly analgesics. And as you'd expect, the older we get, the more chronic conditions we have. I saw a young lady a couple of weeks ago. She asked to go on the oral contraceptive. I was frankly puzzled as to what to do. The average age of my patients is 72. I hadn't seen someone wanting the oral contraceptive for many years. I actually didn't know what it was anymore. But multimorbidity, chronic conditions are here to stay. And as you get older, the idea of living longer is actually quite appealing. Now, one of the interesting things, though, is the association of one chronic condition with another. So if you happen to have, turn around, dyspepsia, you're more than likely to have pain, hypertension, depression, asthma, and diabetes, as well as coronary artery disease. Of course, if you happen to be constipated, you're more likely to have pain, hypertension, dyspepsia, and depression. So I do wonder sometimes whether the medication are actually causing some of the other conditions in terms of what we're trying to achieve. And of course, with chronic conditions comes polypharmacy. So polypharmacy is a patient who's on, in New Zealand we have defined it, 5 or more different medications on a daily basis. They may be taking many more actual items, but it's at least 5 different medications. So, multimorbidity and polypharmacy are increasing. Multimorbidity is because we are surviving longer. Polypharmacy is caused by the existence of multiple, and I do emphasise, because I think there is a question of effective treatments. I'm going to show you some of the systems we use in New Zealand, and one of them is called Best Practice Intelligence. So that basically, on a nightly basis, extracts data out of our practice systems and returns it as information. So it's not real time. So if I was looking today, it would have been extracted at midnight New Zealand time last night. Now my practice is a small practice of 3,000, but on that definition, we have at least almost 1,200 patients who are on 5 or more different medications. I'm pleased that we don't have anybody on 16 or more individual items. So we decided to look at one of these patients, and I'll call him Maud. So this is Maud. In 1 quarter, 7 different doctors prescribed 20 medications to her. But not to worry, most of them were repeats of what other doctors had prescribed already for her. So where are these 7 doctors coming from? Because only 1 came from the practice. Outpatients, ED, after hours. All of them wanted to prescribe. Maud, being a sensible woman, decided not to take any of them. We can, however, use the same system to actually look at a larger population. So we can do this overnight for the country or for a region, a district health board, individual practices or combination of practices. So I just pulled this out this morning based on a region with about 300,000 enrolled population. And you'll see eligibility means they have to be on at least one long-term medication. And here we're talking into the thousands of patients. So if I can deal with Maud, how do I deal with thousands of patients in terms of polypharmacy? So identifying the patients is relatively straightforward. Then trying to deal with it is more problematic. So future directions, guidelines and pathways. The world of New Zealand has gone mad on pathways. I now have 524 pathways I can refer to. I can't remember 5 of them, let alone 524. There's a pathway for everything. So, guidelines or pathways. Touching wires causes instant death, but you're going to get a $200 fine as well. So the problem with double jeopardy. Are pathways and guidelines different? And this is a quote from a colleague. Well, guidelines are a bunch of people, usually hospital specialists, sitting around a table, eating rubbery chicken sandwiches, deciding what was good for us being primary care. Well, the difference in a pathway is that we're now sitting around the table eating the same chicken sandwiches. The issue, of course, is why don't we follow guidelines or pathways? It's because there's a bit missing in the middle. Guidance, then there's a miracle, and it's implemented. People say, why don't primary care general practice implement pathways or guidelines? Well, there's one reason. Your patient does not fit into our guidelines and pathways. Have a good day. Because most guidelines and pathways are designed for people with one condition. My older patients don't have one condition, they have multiple conditions, and no one seems to be able to actually take that on board. But guidelines and pathways are actually very important. It's about utilisation, implementation. So a wee bit about education. So by training, my background is in education. So we formed the Best Practice Advocacy Centre. We thought that education actually works. People said, you cannot change a clinician's behaviour. Well, hold on, the pharmaceutical industry seems to believe you can. So surely we can do that as well. And what we've found now in New Zealand, that reliance on education has now been taken by reliance on decision support tools, point-of-care electronic decision support, which I'll give you some examples of. But it's good to see that the Best Practice Journal and website is way out there in terms of benefit. So we produce a journal which is free of charge. It's funded by the government because demand management, use of pharmaceuticals and laboratories are important to them. It is not a scientific publication in the sense that it has 150 references. It takes good evidence and puts it into practical, implementable terms. We also do best tests. People ask me now for tests that I've never heard of, let alone know how I would interpret them if I even went to order them. You can have tests for virtually anything. Often they will develop a test and then they'll try and develop a disease that you can use the test on. So, does education work? Well, as you know, I'm reasonably older. So when I graduated, the measurement of inflammation in the body was a good old ESR. Well, some bright spark after that invented C-reactive protein. The trouble is no one told me or my colleagues in general practice, so we just ordered both. If one was good, both of them should be extra good. And in fact, there's very little place for ESR. So way back in 2006, we started to say, actually, stop doing ESRs. It doesn't really help. And we've shown significant change. And one of the things, of course, is does it pay? We saved the New Zealand taxpayers $17 million for a price of 1.5 to merely get them to stop doing ESRs and CRPs where it was appropriate. So yes, it does change. And what I want to also show you is Oxycodone. I read a book once from America. I think it's called Hillbilly Heroin. A drug which wasn't round when I was a lad, and it suddenly started appearing, and it was marketed for osteoarthritis. Well, my granddad had osteoarthritis. He took paracetamol and brought a walking stick. So we saw it going up and up, and we decided we needed to intervene. And we have shown a significant reduction in the use of oxycodone in New Zealand. In 2006, 50% of it was initiated in primary care. That's now dropped down to 27%. So primary care has taken on the message, do not start oxycodone, if at all possible. There's nothing wrong with morphine. We know morphine is a good drug. Unfortunately, our colleagues in secondary care still think it's the best thing since sliced bread, and we have an ongoing problem in terms of curbing it. So my message is that focused education certainly can work. Part of that is going with the times. I like to tell people that I grew up with a slide rule. I thought it was a very, very clever thing, the slide rule. Once I'd mastered it, and my first computer looked like an old vacuum cleaner box. It was twin floppy drive, which most of you wouldn't even know what a floppy drive is actually anymore, but anyway. Now, in fact, we've developed e-portfolio systems, both for training and continuing professional development. The users create their records by entering in the information, or they go to a meeting and they scan the barcodes and it records the presence. It doesn't record whether they stay awake, of course, but it does record that at least they have been present. They can undertake self-assessment within their e-portfolios. Auto-population occurs. They then share this with their peer group, with their supervisors, all done online, all done electronically. So this is part of the continuing professional development. So in New Zealand, you must have a professional development plan. You have to undertake a certain amount of CME, peer review, etc. My college traditionally would only recognise if I went to at least an hour meeting and recorded I'd been. Whether I learnt anything from that hour or not was not that important. Now this system will allow me to have an interaction with a colleague for 5 minutes in the corridor or over the phone, which can be a very valuable learning experience, and it allows me to record it. E-port, I do worry about our younger graduates. PGY1 is first year postgraduate. In New Zealand, the medical council says there are 496 learning objectives to be obtained in your first year postgraduate. How on earth do they do that? Didn't know there could be that many learning objectives. But they can now do it using ePort. I want to take you back now to 2005. I had a dream of having a cupboard of mini consultants, in that if I had a problem with a patient with an eye, I could get the ophthalmologist out of the cupboard, get an opinion, and then put them away again. Because I must admit, I find my colleagues in secondary care nice people, but very annoying if you left them out for too long. And one of my friends said, well, I hope there's no one who's a secondary care consultant here. One of my friends who was an IT said, I reckon I could build you that cupboard. And we embarked upon electronic decision support in 2005. Then we had 4 million New Zealanders, 1,200 practices. We were facing the ageing population, the chronic disease. The role of primary versus secondary care was unknown, and we in primary care decided to invest to try and aim for sustainability. The aim then was for decision support to provide the right knowledge to the right person, for the right person to the right provider to improve care, so that we could improve the healthcare decisions, the health of individuals, populations, and measure outcome. So the theory was, if we could increase adherence to guidelines, then we would change outcome, and measured outcomes would then have that clinical relevancy. So where are we today? It's now integrated into the standard workflow. We get on average 140,000 uses of the electronic decision support every working day. It's on 98% of every GP and practice nurse's desktop in the country. I'm pleased to say that we've now launched into Australia and we'll be launching into the UK in autumn. So, basic principles. Take the guidelines, pathways. Have you ever seen a guideline? They're about that frigging thick. And I don't have any room under my bed to put any more under there because it's full of old guidelines. I mean, the difficulty is that they are full of knowledge and wisdom, but how do you find it? So we run a business rules engine, and the guideline is digitalised through our servers. So at a glance, we can have what we call a patient prompt to support the diagnosis. We have clinical modules, and we have intelligent referrals, what we call smart referrals. As an aside, before we had the smart referrals, so colonoscopy, bowel cancer is a major issue in New Zealand. Colonoscopy is basically all done through the public system. 50% of the referrals used to be turned back for insufficient information. Change of bowel habit, colonoscopy pleased. We put in a smart path, none are now turned back because the right information is getting to the right person at the right time. So the patient prompt, basically whatever is done through the prompt, so this system is fully seamlessly integrated in all electronic health records in New Zealand, all the primary care records. I will not use a system which means I have to come out of my patient management system and into another one. It must be integrated, it must pull the information out, and it must write it back in. The patient is treated with, so this one's saying the patient is currently being treated on the diabetes and depression module. It's also saying that based on this record, the system is suggesting the patient should be considered for the chronic kidney disease and the TA/stroke module. How the hell does the computer know more than I do? The computer's good at looking at things in the past. I tend to look at what's in front of me today. We even now are starting patient screening via the web, so we have a contract, primary care has a contract to undertake all the screening and long-term follow-up management of post-cancer prostate patients, because we do not have enough oncologists or urologists to follow all of these people. It's a matter of following the numbers. The computer does numbers very well. The intelligent referrals, I do better referrals to my consultant nephrology colleagues than anyone else in the secondary system. Actually, my computer does better referrals than anyone else in the system. They're all pre-populated, and literally it is just one click of a mouse that the referral is actually written. The complexity. I do not have a single diabetic patient who only has diabetes. They have diabetes, they have hypertension, they have nephropathy, they have retinopathy, they may or may not have a leg. And I have one patient, I forgot who was called Stumpy Smith, that one of them had been chopped off, and asked him how are the feet. So what this does is basically it looks at the likelihood of complications from diabetes. In this case, it's a severe risk. It will tell you why the computer believes the risk is high. It will look at the diabetic foot risk and say, I'd like to do a referral to the vascular clinic or whoever is appropriate. It will allow our colleagues who do the retinal screening to load the retinal photographs directly into the record so the patient and I can then see it. And at the same time, it identifies that this patient has stage 3B of chronic kidney disease, and it will suggest, if required, a referral to nephrology or how to improve the hypertension. So this is the chronic kidney disease module, in which it takes the guideline, puts it into a module where it plots basically the EGFR over time. It then says, I think you need to refer to nephrology, click the button, and it writes a standard referral. I had a patient a few weeks ago. It's not in there because Bronwyn's her real name, but I do have her approval to show you this next slide. She came to see me at 20 to 3. It said she had chronic stage 3B progressive renal disease. I clicked the referral at 2:45. At 10 to 3, the nephrologist replied. And the sod said, no, I'm not going to see this patient. I said I wouldn't swear, but bastard. What he said, Murray, was actually, ease back on the spironolactone. You're holding her blood pressure too low. You've gone over the top. He was quite right. We took that advice on board and her renal function improved. Normally that would have resulted in a face-to-face encounter. He would have set aside 40 minutes for that, and it would have taken anywhere between 8 to 12 weeks. It took 5 minutes. The nephrologists think they're very clever. They still count it as a first specialist assessment, but they're now getting to see the patients that they need to see. The patient thought I was very clever until she said, actually, it wasn't you at all, Murray, was it? It was the computer. Where do I get one? Right. TIA and stroke. So another example, it says this patient suggests you initiate the stroke TIA pathway because they have a past history of atrial fibrillation, and you gods, Murray, you've not got them anticoagulated, and they're diabetic and they're hypertensive, they're at risk. It works out the risk of stroke. There's a thing called ABCD2. Well, I didn't know that. ABCD in New Zealand is how we measure risk of melanoma. Someone got another one for risk of stroke. No one told me. Now, I know there are some younger medics here. I assume you know about ABCD2? Oh, good. Neither the young uns nor the old uns necessarily know. Whoops. So it does that. So, question, do these systems work? So we had an independent HRC-funded study which basically showed that guideline adherence doubled, that endpoints, particularly TIA, stroke, death, or any other vascular events at 90 days dropped from 12% down to 3%. It's a very, very good drug. It's a system. What's of interest, if you actually didn't do anything, the true control, they had 16 TIAs stroke at 90 days. If you did training only, education, it dropped down to 13. But if you just gave them the tool, don't worry about the training, just give them the tool, it dropped down to 6. But if you actually give them the tool and you give them focused education, you almost eliminate all strokes at 90 days. One other thing we do now is that we can stratify individual patients in terms of risk of not readmission, but risk of hospital admission, and we call it the Peony model. So we did this for almost another 1.5 million New Zealanders, then on over the age of 45. You say, well, that's great. Does it work? Well, we found that you can predict the probability of acute admission. If it was over 90%, we found 600 patients, of whom 419 ended up in hospital. We've got about a 70% predictive value, which is very good. This is the computer predicting. Somewhere around there is a manageable number. We put it at somewhere between the 50 and the 60. General practice in New Zealand can deal with 9,000 patients. It might struggle to deal with 20, certainly struggle with 47, 100,000. So what do we do for them? The system does it. So another decision support model is the personal healthcare planning, creating and sharing an update. So the system actually checks through everything from memory, cognitive behaviour, right through to pain, long-term medication, does that assessment at the time of consultation, and then we'll do smart e-referrals to the multidisciplinary team. Don't really need to do anything, just push the referral button. And then, when I get the information back, it comes back into the patient prompt in saying that there's been an update on the personal health plan. So I can say with some pride that every patient now over the age of 75 in Helensburgh has a personal health plan, has gone through the system. We're waiting to see what effect it has in the longer term. So, what have we got now in New Zealand? Is it a perfect jigsaw? Nah. There's a Tilyard. Tui is a famous beer in New Zealand, and what the Tilyard goes is it says a saying, then it goes, yeah, right. So basically it's saying, no, we do not have a perfect system. Is the jigsaw starting to come together? Yes. Is it being driven by primary care? Yes. Are there problems? Yeah. But basically, if the person you're talking to doesn't appear to be listening, be patient. It may be simply that there's a small piece of fluff in their ear. I show this to some of my friends and colleagues in secondary care. They don't get it that they're Eeyore. In the most positive sense. I'm certainly not negative secondary care. When you need to go into the forest, it does provide superb care for you. The key thing is that the majority of our patients need to be kept out of the wood. So, ladies and gentlemen, that's a quick amble through primary care. I have no idea if it's what Andrew wanted, but to be honest, I don't care that much because I enjoyed putting it together. He didn't give me any instructions, nor did I offer to show him the slides before I did this, so he can tell me off afterwards. So.
I knew it would be much better without review, and it was a lot more than I ever expected, even since my visit 4 years ago. This has advanced in ways I didn't even know. On that note, we have learned, as I said, that if we're going to try to process international lessons like the treasure trove that Murray just offered, it really helps when we can have an expert from the United States try to put this in a policy context. And I'm grateful to Marcy Nielsen, who is the Executive Director at the Patient-Centered Primary Care Collaborative, which, if you don't know it, and I suspect you do, is bringing together 1,200 organizations to try to help advance primary care transformation in the United States. And Marcy also brings an extensive history at the state level and working in coalitions, again, too numerous to account for, as well as the Academic Health Center, which Murray referred to many times throughout his talk. So thank you, Marcy, for giving us a brief reaction to Murray's talk.
Thank you, Murray. I learned a lot from your presentation, and what I share in common with you is I didn't really know what Andrew wanted me to talk about. And as you were giving your presentation, I myself started my career in health, in public health, internationally. I was a Peace Corps volunteer, also back in the 80s. And one of the things I learned when I came back to the United States and started to study health policy was that politicians, both at the state and the federal level, unfortunately don't embrace international lessons nearly as much as they ought to. This is not news to any of you out here tonight. Are any of you members of Congress? Anyone? I didn't suspect so. So what I would tell you in a brief reaction is there are so many myths about countries like New Zealand, particularly those with a lot of government funding for your health system and what you can and can't accomplish. There are so many myths about the United States health system and what it does. And then there are myths that are ubiquitous in nature in certainly every country I've ever visited. And so I'm going to talk about three of them very briefly. The first myth, Murray's done a fabulous job of poking a big hole in, and that is countries who spend a lot of government funds on healthcare, in fact, don't offer good healthcare services. New Zealand, spending a little more than 10% of its GDP on healthcare, has better health outcomes than the United States. And you don't have long waiting lines and waiting lists. In fact, you have very sophisticated ways in which to deal with data and offer health care to individuals when they have gotten ill in your health system in a way that is impressive. In the United States, we do that too. We actually don't, in general, have long waiting lists, especially if you're acutely ill. And the talk I would be giving 1 week ago today is different than the talk I would give right now. 1 week ago, Monday actually, my brother, older brother, number one son in our family of four, went to his primary care doctor at 10 o'clock in the morning. He was hospitalized by 1 o'clock that afternoon. He was in an ambulance going to an academic medical center by 6 p.m. And by 9 o'clock that night, he was on chemotherapy with the diagnosis of acute leukemia. He's had quite the odyssey over the course of the last week. And I wish I could tell you he's doing better than he is. But in fact, the issue of comorbidity and polypharmacy is very much a part of what is driving his challenge in even being able to embrace chemotherapy. So what does a researcher do? Somebody who has a PhD in public health? Well, by God, I want to find out which clinical pathway he's supposed to be on. And the clinical pathway that he's on didn't point to all of the behavioral health issues that we needed to deal with in terms of him having taken care of his own health and unfortunately not taking care of his own health before he got to the hospital. So myth number 2, I think, has to deal with the United States healthcare system and what we're good at, which is we're terrifically good at acute care in hospitals and specialty care. But what we're not good at, because we don't fund it well enough and we don't embrace it well enough, and it's what Andrew spends much of his time doing, is my brother didn't go to his primary care physician. He is a smoker who is overweight, who had a number of other like I said, behavioral health issues that he needed to deal with and did not. And so in this country, we do need to look to places like New Zealand and embrace primary care and think about ways in which we can better fund primary care, invest in primary care. We've got some real opportunities, I think, in moving to a system that New Zealand moved to over a decade ago, capitating our primary care system so that we're freeing up providers from a fee-for-service system that just gives them too little time with their patients and not enough time to focus on behavioral health issues. So what do we have in common? What we have in common is this myth that it's all about health care, that we're waiting until the end of somebody's life to give them more drugs. My mom called me at 1 o'clock today, and she'd already talked to 5 physicians about my brother's care. Not one of them, by the way, was his primary care physician. We don't think enough about the upstream realities of our health. Not our health care, but our health. And if you look to the New Zealand statistics, what you will see is that it is true. They spend 10% GDP on healthcare, but they don't do that well in their minority populations. The health disparities in New Zealand look just like the health disparities in the United States. So we can learn from you about how to invest in primary care. Maybe you can learn from us about how to do academic medicine. I suspect not, actually, especially after seeing what data you shared with us today. What we can all learn from our friends who work in communities and work in public health and in social services agencies is health is not health care. And knock on wood, my brother gets back on his chemo tomorrow, and we hope all those drugs work. But I wish 30 years ago we were all working on him to quit smoking and take better care of himself. So no more smoking if you smoke, but cocktails, I understand it's going to relieve our stress, and I could really use one. Thank you, Andrew, for inviting me, and so glad you could all be here tonight.
Question and answer time is between you and good food and wine, but I do want to give folks in the audience an opportunity to ask Tilyard some questions. If you don't mind, I'm going to stay up here with you, but I'd love to lead with one. You mentioned, and we spoke of this yesterday, that you've managed to overcome one of our fundamental challenges, which is getting the multiple sources of information to speak to one another. Any advice or any lessons from how you got this started? I understand in a smaller country there are perhaps a few less challenges, but I'd love to hear some thoughts on that.
The key is a single unique identifier which you can link with without the National Health Index. Before that it was called the National Master Patient Index number. At that stage there were 4 million New Zealanders and 7 million numbers. So they went through a cleansing process. So that's key. Then it's basically working the relationships to get people to agree that the sharing of information, so particularly in a de-identifiable manner, but at some stage you need to be able to identify people. At a practice level you must be able to identify those who need help. It takes time, and it's amazing what data you find being held in some very unusual places, but if you can get access to it, it's a gold mine. Yep.
So initially, I wanted to say thank you because it's a fantastic talk, and it's just really great to hear your accent as I'm a Kiwi. And I guess I should explain. So I'm a Kiwi, but I'm here now. I'm married to an American. I'm a primary care physician. I'm also just finishing my residency in preventive medicine at Hopkins, and so I completely agree with the upstream concept. But I wanted to ask, you initially mentioned that your interest right through medical school and doing internal as well as family practice also was in business, and I wanted to ask how the innovation actually was funded in this and how it was brought to scale, especially things like you mentioned the first specialist assessment was actually paid for as though it was a visit, because I think that with that reformation and funding structure for Blue Sky research right through to the payments of physicians is a gold mine as well.
Yeah. My sons want to know why I haven't set this up as a private business. I think they're thinking more of their legacy or inheritance, perhaps. I've found that finding money for good ideas is relatively straightforward. There's always money, particularly we didn't need much. That whole decision support system was built by a group of people coming together. The first time I had to find 5 colleagues to trial it. In New Zealand, the best beer is Speight's prior to the South. So I bribed them with a dozen bottles of Speight's beer to try it. And once they tried the system, not the beer, they then started to use it. In terms of in the past, a nephrologist in the public system, the nephrology department would only be paid if a patient was seen face to face. Thank God we've got to the stage now where the funders will recognise an encounter, whether it be a face-to-face or a virtual encounter, is still a specialist assessment. So nephrology now can see many more patients without having to put aside 40 minutes. The interest in business, these have to run as a business. I couldn't do it to help private investors. I like it going back into community care. It's just the way I am. So.
What sort of investments is the system making to improve the health of your minority population? And is there evidence to date of improvements in the
Yes. I would suggest it's been much more through public health initiatives, such as increasing the immunisation rate in children, reducing smoking rates, particularly in Maori. If you take the Polynesian population as a whole, and I think it's because of their church affiliation, they work really hard in terms of childhood immunisation, smoking cessation. However, we do have difficulties with lifestyle, so obesity, diabetes, ischemic heart disease, hypertension, gout, common in the Polynesian populations. They tend to see that being larger has more esteem, changing those cultural norms. So we're still struggling. I don't think we have the same issues that they do have in Australia with their Indigenous population, but we're nowhere near achieved what we should have yet.
I think you referred to, first of all, thank you for the talk, and I think you referred to this obliquely, but I just wanted to get some more detail. It sounds like you're practicing in the context of team-based care. I was wondering what kinds of things are done to help patients in their own self-management or self-efficacy in order to be a partner in the plan that you've laid out.
They were some of the other slides that I sort of took out. So certainly, as I'm sure in the States, the advent of patient portals now in terms of direct access to their information, utilisation of that information, access to appropriate sites for education. Coming back to, say, our non-European population, how do we ensure that patient information is culturally sensitive, and particularly we talk about our Polynesian population as if they're one entity. They're not. If you're from the Cook Islands, it's not the same as Samoa, from Niue, etc. Again, we're making slow inroads, but Andrew, referred to capitation. Historically, as a general practitioner, I was paid a fee for service from government. The only interest I had was the patient in front of me, perhaps the person who brought them as well. With capitation, I am now responsible for an enrolled population. It's only 3,000, but it's still 3,000. Because I work in a larger organisation, I'm responsible, part of the team, for 300,000. So capitation has changed my view of where my responsibilities lie.
Has it changed the view of the other people in the community who work together on some of the social conditions?
Yes, I believe so. And in a number of areas we're seeing, one could call it experimentation, where they're bringing their health budget in with some of the social budgets, particularly in the Maori population, to try and actually say, look, health is not just about health, this is about housing, employment, etc.
I'm a radiation oncologist, and I would like to ask you, how do you get the primary care physician involved in the care of cancer survival? Because the problem we face is this: once the patient finishes the cancer treatment, they are stressed, and I try to get them go back to the primary care physician, and we face a lot of reluctance from the primary care physician because they're not familiar with cancer care. And the example is the lady, her father got leukemia. I hope to get a cure with the acute treatment, but the problem is once they achieve remission, how do we come back to see this primary care physician or choose a primary care physician who is comfortable with this care?
Look, and you're quite right, and I'd say in New Zealand that primary care has not necessarily stepped up that well, but because of the increasing survival rates, I was going to use the word burden, but the sheer numbers of patients who are now living post-cancer treatment is certainly in New Zealand, our oncology colleagues and urology just can't cope. If I use prostate cancer, the issue with prostate cancer, it's about what's happening with the PSA. And so traditionally general practice will say, oh, it's still under 4, or whatever the normal level is, you are fine, and not recognise that there's been 3 consecutive increases in the PSA, that it's actually a treatment failure. So what we've put in place is the computer actually will recognise it's a treatment failure, will email the patient direct, as well as the oncologist, as well as the general practitioner, saying that this patient now qualifies as a treatment failure. In New Zealand, they're looking to devolve long-term care or follow-up for breast, bowel and prostate. We're just starting down that pathway.
Good evening. Thank you for the
talk. Tom Shafford from New Jersey. I do have family in New Zealand as well as Australia. New Jersey has twice your population. I'm currently chairman of the board of New Jersey Academy of Family Physicians, and we have the same number of primary care physicians trying to care for twice the population. And the problem that we're facing is there really is not that underlying support for primary care. It still has yet to appear. So in the last 15 years, primary care has been more penalized in my state than anything, with reductions of payments. So basically my question to you is a chicken or an egg question. How solid was your primary care base prior to all the things that you implemented, and how much support did you get both from government and commercial entities?
Yep. The New Zealand health system is based very much on the UK system, and so primary care was and is a foundation stone. The current and past, and I'm sure successive governments, see that the long-term future to deal with the burden of chronic disease, increasing costs, is to actually strengthen the primary care base. In New Zealand, you cannot get to hospital unless you go via ambulance because of trauma without going through a primary care referral process. Only now we're starting to see some of our patients trying to refer themselves directly to our colleagues working as specialty areas in private, but even that is very uncommon. So we are still the gatekeepers. To be honest, I don't know how the hell you'd cope in New Jersey if you have the same number of clinicians, yet twice the patient load, and if you're not supported. So I would suggest that the government needs to invest significantly in primary care. And investment's not always about money. It's actually placing value on primary care.
But unfortunately, a good part of it is financial as well.
Yeah.
Payments have actually gone down in 15 years. It's difficult to increase services.
And younger colleagues like to actually go where they can do interventions and often actually get much better remuneration.
We have 23,000 physicians in the state. 1,100 are members of the New Jersey Academy of Family Physicians. We have an enormous percentage of specialty care.
Well, in New Zealand we have a term, you're buggered. Well, I mean, literally, I mean, where do you start? I take my hat off to... I mean, I suppose the only thing is smarter systems, smarter processes. Since we've been doing this, there's been a revival and interest in general practice. They've actually... Because it used to be that a failed hospital specialist went into general practice. A failed general practitioner became a public health physician. No disrespect to public health physicians, sometimes known as dunny inspectors. But that's what people used to say. And of course, it reflected poorly in terms of recruitment. That's starting to turn around. I mean, the discipline of primary care is complex, professionally so satisfying, but the remuneration and the workforce have to be put in place.
I enjoyed hearing your talk and what's going on in New Zealand. From some of the questions here, we heard about some challenges with smarter systems and smarter practices. There's workforce issues, and there's technical issues, and there's payment issues. Another interesting challenge in the States sometimes is agreement on best practices. So taking guidelines and pathways, even very basic guidelines and pathways, there's lots of disagreement here. So I'm interested in two things. Sort of, A, what's the culture in New Zealand around this? Is there more agreement? And then B, how do you deal with that in a technical aspect with your guidelines and prompts, but also in the terms of implementation of care?
Yeah. We often talk about clinical jazz, which I think when I first heard of it was coming out of the States, Larry Green, Roger Rosenblatt. And jazz, if you like jazz, is a mixture of improvisation and structure. So when we talk about clinical jazz, you've got the structure of the evidence. The improvisation is what do you know about that patient and their family or their whānau, the surroundings. Because all evidence doesn't work, nor total improvisation is pure mayhem. We find that The days that our colleagues used to come and lecture to us have gone from secondary. They now come and they actually meet with us because their problems they're facing, they realise if general practice doesn't deal with them better, they get swamped. They cannot cope. They cannot cope with the burden of the prostate cancer survivors, etc. You'll never get 100% of people agreeing. Sometimes my job is to make sure general practice behaves itself when our colleagues are present. But if you don't start, I mean, it's an amazing journey.
Last question.
All right, thank you. I was really excited by how data is used in the system for the innovation pathways. You spoke from the perspective of primary care practice. Clearly, it's networked with specialist physician care, but I'm particularly interested, sort of two questions. Interested in how other healthcare providers are connected to the system, if they have access to that, whether they have access to some of the same kinds of data in the system as well. I'm a psychologist, so I'm particularly interested in that area. I'm also then interested in behavioral health specifically. Like the previous question, we don't always have agreement. In behavioral health, we can't agree on whether or not we should be included in these kinds of things because there are some who think what we do in mental health care is so private, it shouldn't be shared at all with others, which is a real challenge to overcome. I'm wondering if you've run into that attitude in New Zealand.
Yeah. It's interesting. We've had quite a number of focus groups, and particularly in the area of mental health, for the same reason that, oh, no, we can't share information. When you actually talk to the clients, they're actually quite comfortable with it being shared amongst the appropriate providers. Sometimes they say, well, we thought you did anyway. Why aren't you? The best example, we're getting in much more into the team environment. So new facilities are being built. Co-location is occurring. The long-term plans now with the referrals to that multidisciplinary team are really starting to take off. Because while as a primary care provider I may be able to identify an issue, doesn't mean I can deal with it. But if I can transfer that care in a way which enables the next provider to pick it up, and the information is then flowing back seamlessly, patients are starting to embrace it, as are providers.
Thank you to Dr. Tilyard and to all who came tonight. And I think we're ready to move on to a more social part of the event. I'm sure Dr. Tilyard.
Well, can I ask one question?
Please.
Have you got spades? Have you got spades spare?
We might actually, downstairs.
Oh, that's in the private bar downstairs.
For the rest of you, we'll stay up here and join at the back.